All right, good afternoon, everyone. Thank you for joining us for this mentor training session on the clinical reasoning tool in mentorship. So just a few notes as we get started here. We suggest that you close other running applications to help maintain a stable audio and video connection. If at any point your connection freezes during the presentation, try exiting GoToWebinar and coming back into the session. The recording and slides for this webinar will be posted on the mentorship program webpage within a few days of today's session. And as we're going through the webinar today, if you have questions, please put them in the questions box on your screen. Our colleague Jessica Laforette will be monitoring the questions. So I'm Samita Joglekar. I'm the Audiology Advisor and Manager of Mentorship at CASLPO. And I'm joined by my colleague, Sarah. Sarah, would you like to introduce yourself?
Thank you, Mida. I'm Sarah Chapman-Jay, and I'm Advisor for Speech Language Pathology, Professional Practice, and Quality Assurance. Good afternoon to you all.
Thanks, Sarah. All right, so our agenda for today's presentation will begin with some brief background information. Then we'll get into the mentorship version of the clinical reasoning tool, or the CRT. I'll just point out that the mentorship version of the clinical reasoning tool is attached as a resource today. So if you'd like to click on it and download it now, you can do so. We're going to listen to some audio examples of clinical reasoning as well from both speech language pathology and audiology. And then we'll get into using the CRT with a mentee. And of course, we'll get to your questions. So let's get right into the background information. So we do have a previous e-forum on the clinical reasoning tool that we did last year on development, evaluation, and remediation. So that session is more about how the clinical reasoning tool was developed and how it's being used in the quality assurance program. Today's session is, of course, about how we're implementing the clinical reasoning tool in the mentorship program. And today's session is for you as mentors to help you use the clinical reasoning tool in mentorship with your mentees. So we know that health regulators across Canada use different methods to evaluate their registrants' clinical reasoning. For CASLPO, we use the clinical reasoning tool as part of the quality assurance program's peer assessment process. Clinical reasoning for our professions is an expected entry to practice competency. And it's also a skill that continues to evolve across the career stage. So if I reflect on my own career as an audiologist, I can remember how when I first started practicing, what sorts of questions I asked or the approaches that I took in my practice. And then as I saw more patients and encountered different and varied clinical scenarios, how my clinical reasoning changed and evolved over time, and how it's much different today compared to how it was at the beginning of my career. And I'm sure all of you watching can relate to that experience as well with your own clinical reasoning. However, because clinical reasoning is an expected entry to practice competency, initial registrants or mentees are expected to apply and demonstrate clinical reasoning skills during their mentorship period, of course, that are in line with their career stage and with their level of experience. So the mentorship period as a whole is a process that supports and facilitates the competency of initial registrants and prepares them to become self-regulated health professionals. We know that the application of clinical reasoning is an important competency. Up to this point, we haven't really been evaluating this competency, but now we have better tools to do so, such as our clinical reasoning tool. And this is why we've integrated the clinical reasoning tool into the mentorship process to help you as mentors support and evaluate clinical reasoning skills. Another reason we want to bring the clinical reasoning tool into the mentorship is to mitigate risk, and we call this risk-based regulation. So our goal is to mitigate the risk to the public of having new SLPs and audiologists practicing in Ontario without enough application of clinical reasoning skills. We want to identify initial registrants who need to work on this skill early in their career. And then we want to remediate issues with clinical reasoning through the mentorship process. And that's why your role as a mentor is so important and critical, as you will be supporting and guiding initial registrants through this process as well. So let's talk a little bit about what clinical reasoning is. So clinical reasoning describes the process by which we as health professionals collect and evaluate information, come to an understanding of a patient problem or situation, plan and implement interventions, evaluate outcomes, and reflect on and learn from the process. It's really what you are doing every day in your clinical practice, probably without consciously thinking about it. Clinical reasoning is also being able to reflect on and explain why you did what you did with a particular patient or in a particular clinical scenario. And it's learning from this process on a continuous basis. So being a lifelong learner, always asking questions or thinking of different approaches that you could take, and always striving to become better and better in your practice. Another important thing to know is that the clinical reasoning tool is based on chart-stimulated recall. And we know from research that chart-stimulated recall is useful for a variety of things that we've listed here, including identifying critical thinking and reasoning skills, stimulating reflective practice, improving documentation, record keeping, and also to identify gaps in knowledge. So the Mentorship Self-Assessment Tool, or MSAT, has a new practice indicator on clinical reasoning as of October 1st. So mentorship periods that you begin with a mentee from October 1st onwards will have this clinical reasoning indicator listed, which is indicator 3.7. In the MSAT, the clinical reasoning indicator is a red flag indicator. And what that means is that mentees are expected to meet this standard of practice by the midterm evaluation. So as a mentor, you will be evaluating the mentee on this practice indicator, and the mentee will also be self-evaluating on the indicator. We also just want you to know that the MSAT has 3 more new practice indicators in addition to the clinical reasoning indicator as of October 1st. And these include indicators on conflict of interest, advertising, and professionalism. However, clinical reasoning is the only new red flag MSAT indicator. All right, so that brings us to the end of the background information. We'll now move into the next section, which I'm going to pass it over to Sarah to take us through.
Thank you very much, Samida. So let's take a closer look at exactly what the mentorship version of the clinical reasoning tool looks like. So this version was actually developed, and it was based on the quality assurance program version that was we put into place 3-4 years ago. So this is really being created for the mentorship, and you can find this on the mentorship webpage, and it's also included in the MSAT itself. So you can see here the red arrow, the 4th area where you can click Clinical Reasoning Tool Mentorship, as well as a direct link into that tool. So these are all available for you as needed. So the clinical reasoning tool for mentorship is to help both mentees and mentors facilitate and apply clinical reasoning skills. It's really designed for mentorship as a supportive and educational tool, and the purpose is to assist mentors and mentees to evaluate clinical reasoning and monitor how these skills evolve during the mentorship period. So some things to note as a mentor: you are not required to submit completed clinical reasoning tools to CASLPO or in the MSAT. You're also not required to score the clinical reasoning tool. And just as an aside, It is required for peer assessors in the quality assurance program, but we are not asking you as mentors to do this in mentorship. However, there is a suggestion that the mentees can attach their own completed clinical reasoning tools in the MSAT as their own evidence for meeting the standard of practice. And to be honest, it really does work well as a self-reflection exercise. So as a mentor, you are required to conduct the clinical reasoning tool with the mentee by or at the midterm evaluation meeting. You're also required to consider the clinical reasoning tool discussions when you're determining your rating for the mentee on the clinical reasoning indicator. So your choices obviously are going to be either meets the standard or needs work to meet the standard. Also, you will be required to comment on your observations of the mentee's application of clinical reasoning skills, both in the midterm and the final reports submitted to CASLPO via the MSAT. So as a mentor, you'll be observing the mentee demonstrating or applying clinical reasoning, not only when you're using the tool, but any time during the mentorship period when you're working closely with the mentee. The tool really is something additional to help you in evaluating that competency. And research that we did back 3-4 years ago when we were looking at it for the quality assurance program did confirm that the clinical reasoning tool provides a solid framework and a validated method for revealing clinical reasoning. And that's why it seemed like a great idea now to integrate it into the mentorship process. Okay, so let's now take a closer look at the mentorship version of the clinical reasoning tool. It's important to note that there are some key processes we're looking for when you are considering clinical reasoning. So you want to ask yourself, has the mentee collected sufficient information? So that could be to do with developmental history, medical history, who's involved in your patient's sort of network of family, colleagues, with children. It could be in school, preschool, all the different settings that they're going to be in. Are you applying that background? Sorry, is the mentee applying that background information or clinical information in their decision-making process? Are they linking that information from one phase of intervention to the next? So it would be fine collecting all that information, but if you then don't use that information to help inform your assessments or your intervention, your treatment, and discharge planning, then it all needs to be linked in together. You need to think about how it's all connected. And obviously, patient context is key. You're always thinking of being patient-centered, taking into consideration their specific situation in all areas of intervention decision-making. Also, is the mentee considering options? And is there a reasonable rationale why they have chosen one particular option versus another one? Are the mentees showing flexibility in their approach regarding each unique patient, all their unique needs, and considering possible intervention options? And finally, but just as important, can they provide a reasonable rationale to explain why they did what they did? Now, we are often asked, what is the definition of reasonable? And it is what a hypothetical, typical registrant who exercises average care, skill, and judgment would do in similar circumstances and thereby serve as a comparative standard. So at this point, I think it's going to be helpful to actually look at the tool itself. It's made up of, I want to say 3 pages. It might be 4. I believe it's 4 pages, pages 4 to 7, right there at the top. So the first section is patient overview. There are in total 9 prompting questions as part of this tool. And you can see on this first page, there's question 1 and 2. So let's just take a look at the first question. Briefly, give me some background information about this patient. You're going to ask that question and get the response from the mentee. Now, you can also see there's some bullet points there. Now, you might ask somebody this question and they say they're 4 years old. Well, that's not a lot of background information to go on yet. So looking at the little bullet points, you might want to do some extra probing and you might say, well, tell me some reasons why this child was referred. Is there any previous assessments that you're aware of? Are there any particular challenges this child is having, maybe in their preschool or school setting? Can you give me some interesting background information that will help me understand your child more? So you're really looking at ways to probe a bit more, only if necessary. From experience, there are some people who can share all the information with you very readily, very easily, and others may just need some of this prompting. On the right-hand side of these pages, you can see an area called comments. And this is for your own free use, also for the mentee's use. If they're going to use it as a self-reflection exercise, they can fill it in themselves. And you can see that we have a legend at the bottom of each of these pages. So that refers to all the processes, collecting information, applying it, linking, taking into consideration the patient context, any options, all options, being flexible, and being able to demonstrate reasonable rationale. So again, you can see there's different sections. Now we're on the discharge planning, so that goes with question 8. And then the very final question I like to include as well, because this is more self-reflection after you've gone through sort of the whole intervention that you may have carried out with the patient. So the last question is, knowing what you know now, is there anything you might do differently? And I know when I started out, this was a question I asked myself all the time throughout the day, probably at nighttime, waking up during the night. Why didn't I think of that assessment? Why didn't I check the voice? Why didn't I look at, I should have tested the other part of the hearing. I should have done this, that. So we're always asking ourselves these questions. And this tool, as I say, is really, it's like a framework. It's something we can all use. Not just for mentorship, you're free to use it in other ways, but today the focus is on how you can use it on mentorship, for mentorship. So let's look at some tips for mentors. You can skip prompting questions if the mentee provides enough information on their own. The prompting questions are here to help you elicit more information from the mentee about their clinical reasoning. So it is a framework. There's not a set way that you must ask all 9 questions. If they've given you answers to question 1, 2, 3, 4, and 5, you can move on to question 6. The other thing is you will find not all sections of the clinical reasoning tool will apply to every mentee or patient. As Samida mentioned earlier, some of you as registrants only do screening, some only do assessment, some only do consultation. So you can design it to fit each mentee and patient situation. Again, this isn't that you have to score this. So you don't always have to use the check marks for all the processes in each individual box with the questions for it to be an adequate clinical reasoning. However, you do want to see that the mentee addresses those processes at least somewhere in the explanation. The other thing is, what we're hoping with this tool is that you may notice some patterns. It could be that they are describing how they did the assessment, they've got their plans, their goals, but somehow they're missing patient context. What are the patient's interests? What goals does the patient have? It might be fine for you to have your own goals, but if it doesn't match with what the patient is wanting or needing, then that could be an area that would need a little bit of facilitation and support as a mentor to the mentee. Or they may neglect taking that information. They got very useful background information, and then they forgot to apply it when it came to the assessment or the intervention. Something we noticed in quality assurance was there is no time limit on how long this might take using this tool. When we were doing the research, it showed that it could range from maybe a very short time, 4 to 5 minutes, or it could be as long as 30 plus minutes. So please don't feel restricted from the time perspective. There's no need to worry about that. And as a mentor, it will be up to your professional judgment to determine if there's enough evidence of the mentee's clinical reasoning and if the skill has been applied. Again, as Samita mentioned earlier, you're not expected to teach clinical reasoning. This was already a core entry to practice competency. What you may find, though, as we just said before, is that you may need to facilitate, say, certain areas, maybe increase the amount of options they're looking at. You might be looking at just encouraging them to be a bit more flexible in their approach if their choices are maybe too limited. And really, finally here, the clinical reasoning tool is a tool that we hope will assist you during mentorship.
Excellent. Thank you so much, Sarah. So that takes us to the end of that section, and we will stop to take some questions now. So Jessica, are there any questions that have come through?
The only question I have is from one person that says, can a mentee work in his or her own business or organization with a mentor outside of the organization?
So that could be possible.
Yeah, an initial mentee.
So is the question, is it suggesting that the mentee has their own business, their own private practice, or?
Yes.
Okay. So we do have some information about initial registrants and private practice in the mentorship guidelines. We highly suggest that mentees don't do a large amount of their own independent private practice during mentorship. They can be doing a small amount of private practice, but it has to be in addition to another job that the initial registrant has, where they're doing most of their practice hours. So there is information about that in the mentorship guidelines. About working with a mentor outside of an organization, that is possible to do. So a mentee doesn't necessarily have to have a mentor who works with them at the same workplace. They can have an external mentor who works elsewhere but is mentoring them for the work that they're doing, say at a hospital or at a private clinic. So I hope that that answers the question.
Another question came in and it says, could you remind us of the amount of patients we need to review with the mentee for the 9 questions? And this question comes from a mentor.
Okay. So the number of patients that you need to review, I think I'll turn to Sarah too for this, but I believe all of the questions in the clinical reasoning tool, you could be going through all 9 questions about one patient, about one particular clinical case. So all of those questions could possibly be relevant. So you don't have to be splitting the questions between different cases, but you would take one case of a patient and you'd go through each of those sections and questions. But as Sarah mentioned, sometimes all of the questions may not be relevant. For example, if you work in a setting where you only do assessment, but you don't do treatment, then you would go through the questions related to assessment. So case history, how did the case history inform your assessment process, those types of questions. But then you wouldn't get into the treatment related questions. Sarah, does that, do you have anything you would add to that?
Yeah, I think again that's exactly as you were saying, Samita. You're going to design, these are questions that are prompting questions, but you need it to fit with each mentee and each patient that they're dealing with. So there are different sections. There's the overview background, there's the assessment, screening and assessment management. Maybe they are not involved in that at all, in which case that section is not applicable. So really the mentee will be knowing which sections are most applicable to them, as hopefully you would as well as the mentor. Yeah, hopefully
We are
that
going to,
answers the question.
yeah, we are going to talk a little later in the presentation about how many cases we want you to talk about with the mentee. So that might help a little bit as well. That'll come a little later. Any other questions, Jessica?
No, that is it for now.
Lovely.
That's it for now.
Okay, great. So we're going to go into the next section, which is the clinical reasoning examples. So
Absolutely. So the clinical reasoning examples, we have got 4 examples for you, 2 audiology and 2 speech language pathology. And we will let you listen to the audio examples of the clinical reasoning discussions in both professions. You will recognize the voices. We have just done sort of a pretend clinical reasoning tool demonstration. Voices are either CASLPO employees or consenting family members enacting the discussion. These examples are fictitious. In the interest of time, we're also going to let you know that we're only playing a portion of the clip, but we're hoping that we give you enough for you to determine whether you see clinical reasoning here. Okay. The other thing we just want to add is if you lose the audio or visual, just give us a few moments, because when we're moving from the PowerPoint to the video clips, there might be a tiny delay. Please don't panic. But if for some reason you really have lost the audio and visual, log out and log back in. Okay, so I hope you enjoy listening to the examples.
that's perfect. Thanks, Sarah. So we're going to start with a speech language pathology example. Can you briefly give me some background information about this patient?
Yes, he was referred from long-term care home, and they requested a speech and swallowing assessment. So he was ready for a diet upgrade, and he'd been on a modified diet and he wanted bread included. So I went ahead, I did a swallowing assessment, and thankfully the diet upgrade was possible and we were able to have that implemented. But while I was doing the swallowing assessment and the recommendations for the diet, I also realized that we needed to look at his communication.
Okay, so what was unique about this patient?
Well, I noticed that there was very limited verbal output, and I really was questioning his ability to comprehend everything when we were sort of doing the assessment. Now, the medical history, that included a carotid artery occlusion, right internal carotid artery stenosis, diabetes, hypertension. He had had a previous stroke. And I also confirmed this with his spouse and the doctor to verify that, you know, if there was any other additional information.
Okay, great. So moving on to your assessment, can you tell me how did the background information that you collected direct to your assessment?
Yeah, so obviously I had already dealt with the swallowing diet update. So now we're concentrating on assessing his communication skills and collaborating with long-term care staff and his wife, as well as, of course, the patient himself.
Great. So can you lead me through your assessment process?
Yeah. I did do the Western Aphasia Battery with him, and basically the outcome was that yes, he was severely aphasic. He did have 1 or 2 automatic phrases, easy, easy, yeah, yeah, yeah. So for me, I went back to the books and checked in what would be recommended for global aphasics.
Okay, so we're going to stop that clip there and return back to our main screen. Okay, everyone. So based on what you heard in that clinical reasoning example, we're going to put out a polling question to you. So based on what you heard, did you feel that the clinical reasoning meets the standard, needs work to meet the standard, or are you unsure? We'll just give a moment for people to respond.
It's always nice to be reassured that people are out there as well, isn't it, Samida, that they are
It is. I can
actively
see.
responding.
Yep. So I can see the responses are coming through. We're at about 25%. So I'll let it
Excellent.
go for another 5 seconds and then I'll close the poll.
And again, just while they're doing this, just remind you, we haven't gone through the entire tool, but hopefully we've given you enough to make some kind of decision on this.
So as you can see, we have 83% of those of you watching feel that it met the standard, 11% feels it needs work, and 6% are unsure. So we'll hide those results and we'll go back, and maybe Sarah, you and I can discuss a little bit, looking at the clinical reasoning processes that you took us through and that we were looking for in that example. We feel that this was an example of clinical reasoning that was meeting the standard. Maybe you can talk a bit about what types of processes were demonstrated there in that example.
So absolutely, they'd collected some background information and they were applying that background information to the assessment choices, making a link from one part of intervention to the next, taking into consideration the patient's context. Now, as we said, this was only part of the clip. That you didn't hear is that the speech pathologist did go on to really identify the patient's interests, choosing suitable treatment options that were really geared around what what matters to them. They were in a home, so finding communication boards that would work in that situation. So I think yeah, we certainly saw some of the processes that would be typically the options and flexibility you see a little bit more in the management section. So I think again, it's not easy to make a firm decision, but overall, the direction it was going, things were looking good. Anything else, Samida, there?
Yeah, no, I would agree with the direction it was going in. I saw flexibility and linking of information as well, or I heard. So it was definitely going in the right direction. We will be posting the audio examples of clinical reasoning as well for those of you listening who would like to go back and listen to those again. So let's go to the next example. And it'll just take me a moment to get it started. This is an audiology example.
Okay, so again, you're going to be listening in to those processes and seeing how well they apply to this clinical reasoning example.
It's just taking a moment for it to load. Okay, here we go.
Okay, so can you briefly give me some background and tell me what was unique about this patient?
All right, so this is a patient who has been coming to us for a few years. I believe he's a retired teacher, maybe about 72 or 74 years old, I think. Sometimes he comes in for cerumen removal, sometimes it's for other things. But on this particular occasion, I think he came in with, oh yeah, he came in with the complaint that he woke up one morning and he had lost his hearing in his left ear, completely and suddenly. I mean, I don't have the audiogram from that time here with me or anything, but he said that he took some prednisone and then his hearing basically returned. But his right ear, it has a very mild high frequency hearing loss. And well, he's about 72, I think 72 or 74 years old. So, you know, I told him that's to be expected. But, you know, my feeling is that his hearing has always been symmetrical between the right and left ear. I mean, I don't have the hearing tests with me, but that would be my guess, you know, based on memory.
Okay. So could you lead me through your assessment process? How did you go about assessing his hearing?
My assessment process. Let me just look at the file. Well, so on this day, he was mild to profound. I think that's profound. Is that 80, 100 dB? I think, yeah, I think that's mild to profound loss in the right ear. So I basically wrote acute hearing loss in acute hearing loss in August, and then I wrote resolved because he reported it was resolved. But in fact, it's probably resolved compared to what it was because he said he couldn't hear at all. So, I mean, he took prednisone and that gave him some relief. So. All right, we're going to stop that one there and we will come back. Okay, and we're going to put out the same polling question. Do you feel the clinical reasoning that you heard meets the standard, needs work to meet the standard, or are you unsure? I can see some responses slowly coming through. Okay, and now we have lots coming through. We're at about 50% of people who have put in their votes. So I will close the poll and share those results. And the great majority feel it needs work to meet the standard. We don't have anyone who said it meets the standard, and a couple who are unsure. All right, so let's talk a little bit about this one. What I heard was maybe an example of a mentee who is kind of struggling to put together a coherent explanation of what they did with this particular patient that they were working with. We didn't really hear that they had collected a lot of background information or that this information was being applied. When the mentor asks, can you tell me about your assessment process? The direction of the answer is not really to answer the question of what was done in the assessment. So that's where you as a mentor may need to come in with some of those prompting questions that Sarah went through. When you have a mentee who you need to elicit more clinical reasoning, that's when you could use some of those prompting questions. In this case, you know, collection of information, applying that information and linking it wasn't really coming through in the explanation so far. Sarah, would you add anything?
Yeah, I think the specifics were missing there a bit, wasn't there? We weren't getting a clear picture of, well, what kind of hearing loss was it? I mean, we went from mild to profound, and the information being provided seemed inconsistent, almost as if they were guessing. I think they were referring to their documentation, which is another point. This is why we need clear documentation. We should be able to refer back to our records and know exactly what our assessment results were. So was it 80? Was it 100? Was it mild? Was it profound? So I think that's important. And then linking that information, again, we didn't hear the second part of this clip, but then being able to link that assessment information to the treatment options as well. So yeah, I think definitely some assistance here would be good.
Right. Okay, so let's move to our third example. So we're going to go back to speech language pathology. And here we go. Tell me what is interesting about this case.
Well, the boy, his parents were concerned about his stuttering. So I talked to the mum on the phone. She didn't have concerns about his sounds or his words, just his stuttering. So I took her at her word and I just assessed stuttering.
Okay. So how did you choose your assessment?
I usually go with a speech sample.
All right. And what would lead you to choose that method over maybe other methods that are available?
It's an undiluted snapshot of the child's speech.
Okay, so can you tell me, how did the assessment process help you develop your recommendations or your management plan with this child?
Well, he's 4 years, 7 months. He's hardly stuttering at all. I took mum's word for it. I said to mum, most of the time it just goes away if you just wait. He'll be out of senior kindergarten this year, and then next year he won't be able to receive services. But let's just wait and see. And then mum called me 2 months later and says it just isn't any better. So I took her at her word and I started with the Lidcombe approach. I had some new speech samples, which now showed a mild to moderate level of stuttering.
Okay, so how did those assessment plans change your therapy plans?
Oh, didn't change it at all.
Didn't change it at all. Okay. All right, we'll stop that one there.
Hi, sorry, I just wanted to come on and say that people were having trouble seeing the screen. I wasn't having trouble, but sound and the screen seemed to not work.
Okay, I
Sorry.
apologize sorry if that happened to anyone out there. We're still just going to try to poll you on those of you who did hear that example. Hopefully some of you heard how you felt about that clinical reasoning. We'll just give
And
you...
hopefully we can, yes, Samita, hopefully, and Jessica, we can reassure them that on the recording, it should all be posted again. So, you know, we should be able to hear the audio and video on the recording itself. So apologies to anyone that this hasn't worked during this actual live recording.
Yes. Okay, so I'm going to close the poll and share the results. And most of you feel that that was clinical reasoning that needed work. And we would agree with that. Sarah, maybe if you wanted to just briefly comment on what was missing, some of the processes that were missing in that example.
Yeah, so I think here we're talking about the rationale. There seemed to be a lot of saying, I just took the mum's word, rather than using their own professional knowledge and skills and judgment in terms of assessment options. They went with a speech sample. There could have been other options, exploring different inventories, rating scales. Yeah, so that could have been expanded on, making that link, and even sort of the consistency, saying, okay, well, it was just stuttering, but you'd still want to look and even informally check, articulation, speech, language, receptive language, etc. And showing some flexibility when asked, how do these assessment plans change your therapy plans? The answer was didn't change it at all, which to me is not reflecting on what the options are or how to be flexible in taking that next step.
Right.
Anything else, Amida, at all?
I would agree with everything that you've said. So we do have one last example that we will listen to. In the interest of time, we won't do the polling, but we'll listen to the example, have a quick discussion, and then get into the last section of the presentation.
Can I just suggest something before the next example?
Sure.
Yes.
Some people have let me know that when they couldn't hear the sound, logging out and logging back in solved the problem quickly. So thank you for those who let me know that.
Excellent.
Thank you.
So try that. Okay, so we'll get into, thanks, Jessica. So we'll get into the last example. And here we go.
Can you briefly tell me about this patient and what makes them an interesting or unique case?
So this client was a 9-year-old that I met with his mother. He was a brand new patient to me, and the referral was from a family doctor saying that he had a diagnosis of ADHD and was on medication. The rest of the referral was a bit difficult to read, but it said, mother concerned regarding hearing. So that's what I had to work with. So I picked up this fellow and his mother from the waiting room, and we walked down to my office. They were very pleasant upon meeting them. I noticed, even as we were walking down the hall, that the boy was full of energy, very energetic. He was bouncing down the hallway. And so he sat in my sound booth while I, about 5 feet away, went through case history with Mum and involving him as well in the discussion. And I collected information regarding what their concerns were. So the main concern from Mum was that he's having some difficulty in school right now. The boy also confirmed this. Not sure if it's attention and focus or if there's a hearing problem. No history of ear infections. In terms of infant hearing program history, he was born in 2009, so he would have had IHP hearing screening. Mum did not recall what the results of the IHP screening had been, but that's not so unusual, so we continued on from there. There were no concerns that the mother had about acquisition of speech and language, and upon hearing him in the office, his speech was articulated well, and he was conversing with us and answering questions. And Mum did confirm the diagnosis of ADHD from the referral, and also explained that they were working through dosages at the moment because he was growing very fast, and so the dosage of his medication was still being negotiated. There was no significant family history of hearing loss reported or any other major concerns in the case history. Okay, I'm going to stop it there, and we'll take us back to our main presentation screen. So just in the interest of time, I think we'll have a quick discussion about this example we just heard and then move on from here. So I would say we didn't listen to the whole thing, so we didn't get to hear the whole explanation coming from this mentee. But from what we heard, I feel, again, that it was on the right track. We could tell that even watching this little boy who was the patient coming down the hallway, this mentee was making observations and starting to collect information. She was drawing on knowledge, applying some of that clinical information as she was talking about the case history. So it was an example that we're on the right track. Of course, we didn't get to hear the whole thing. Sarah, what do you think? What are your thoughts?
Yeah, I agree with you. You know, definitely taking the patient's context. We know that he has ADHD, so trying to accommodate that as well. Yeah, and really looking at what the challenges are, the background, history, the behavior. So including some, you know, the situation and the patient was good to see as well.
All right, thank you. So we hope that listening to those examples helped to kind of put the clinical reasoning tool in context and give you some idea of what it might be like to go through this with a mentee in mentorship or even with a colleague. As Sarah said, we want this tool to be something you can use in lots of different situations. So let's finish off with how to use the CRT with the mentee. So in bringing the clinical reasoning tool into the mentorship, we actually consulted with a focus group of peer assessors who also mentor. And their feedback was integral to how we are asking you as mentors to use the clinical reasoning tool with your mentees. When we talked to the peer assessors, they offered a lot of great insights. One insight was that unguided conversations can restrict you to your own thinking patterns. So the clinical reasoning tool is a nice tool in that it brings a level of consistency to these conversations. It provides a nice framework, and it provides an opportunity to ask questions you wouldn't normally ask, like that reflection question. If you saw this patient again, what would you have done differently? It structures the conversation and facilitates a pattern of logical reasoning, and it generates opportunities for learning, coaching, and self-reflection. So because we have this great tool, we encourage you to use it early in the mentorship and over the course of the mentorship, because it is going to provide that structure for those discussions. And we know that it is a valid and reliable tool at revealing clinical reasoning skills. And it's going to help you as mentors and your mentees track progress with this skill, and also help to identify any gaps in knowledge that need to be addressed. And you're going to be having these discussions with the mentee as part of the mentorship anyway. So bringing the CRT into those discussions will be quite helpful in just structuring that conversation. So in terms of instructions on how to use the tool, there are instructions on page 2 of the CRT for mentorship. And there's also a section on the CRT in the mentorship program guidelines on page 16. And all of that information is in line with what we are talking about in the webinar today. So as a mentor, you are required to use the clinical reasoning tool with every mentee. For mentorships that start from October 1st onwards, you will see it reflected in the MSAT as well. Of course, you can use it for mentorships that you've already started before October 1st as well, if you wish to. Again, our suggestion is bring the CRT into the process early. Use it early in the mentorship as an approach to discuss patient cases. And use it as an educational and coaching tool to create opportunities for learning and support reflective practice. As a mentor, you will complete the CRT with your mentee by or at the midterm evaluation with at least 2 patient cases. And we suggest that 1 case be selected by the mentee and 1 by you as the mentor. And anyway, as part of the mentorship process, 5 cases are to be prepared for record review at the midterm. So you could select the cases for the clinical reasoning discussion from those 5 prepared, or it could be cases from outside of those. It's totally up to you and the mentee. So as a mentor, you will conduct the CRT as outlined in the previous training section that Sarah took us through. And here's a few things to keep in mind when you're going through the clinical reasoning tool. So again, as Sarah said, not all sections will apply to every mentee or patient. It depends on the clinical scenario or model of care. Also keep in mind that you can skip questions if the mentee has already provided the information. You can skip to different sections. And it's not expected that all areas of the clinical reasoning tool will be documented in the patient record. Keep in mind as well that you're listening for the mentee to demonstrate their clinical reasoning skills. So can they explain why they did what they did with that particular patient or in that particular clinical scenario? And you're listening for the mentee to talk about those processes. Did they collect information? Did they apply the information? Were they reasonable and were they flexible? Also to keep in mind when you're going through the clinical reasoning tool is you are considering if the mentee's application of clinical reasoning is reasonable. And we talked about the definition of reasonable, what a typical registrant who exercises average care, skill, and judgment would do in similar circumstances, and thereby serve as a comparative standard. So Sarah, I'll pass it over to you to go through our tips for mentors.
Thank you, Samida. So some additional tips. Obviously, the mentee may need some more factual information when they are starting out. You might have to orient them to a new clinical practice area or a new electronic record keeping system. Initial registrants will express their clinical reasoning differently from more experienced registrants. They may have a different decision-making process than what you would expect, but we are asking you to be very open-minded and listen to their perspective and really consider, are they making a reasonable decision about the clinical reasoning? And are they meeting the minimal expected practice standards with their approach? Really, what you're focusing on is the content of the mentee's clinical reasoning explanation. Not being asked to evaluate the quality or the style of the mentee's communication, how eloquent they are when they're discussing it, what vocabulary they're using, how expressive they are. We had a joke, I would say integral. Samida says integral. You know, that's not the issue here. We're really focusing on the content of the clinical reasoning explanation, and obviously being responsive to cultural, personal differences in each person's communication style, very important as well. When you've gone through the clinical reasoning tool, if you're unsure if the mentee has demonstrated clinical reasoning, you're going to ask yourself, does the mentee independently recognize where they need to improve? Does the mentee ask questions and seek feedback to improve their understanding? Does the mentee make efforts to learn in order to meet practice standards? And really, if the mentee is doing all of these things, showing their self-awareness, really analyzing their clinical reasoning skills, this is a sign they are on the right track.
Excellent, thanks, Sarah. So we're just going to conclude with a few last slides on the MSAT and what's required in the MSAT for you as a mentor. So firstly, in the MSAT, you will be indicating a midterm rating for the mentee on the clinical reasoning practice indicator, and that's in the professional practice standards and indicators section. And as a mentor, you're also going to confirm that you have used the clinical reasoning tool with the mentee and comment on the mentee's clinical reasoning skills in the midterm mentor report and CRT section. So here are some screenshots from the MSAT. In the professional practice standards section, you'll see that indicator on clinical reasoning, which is a red flag indicator, 3.7. And in the mentors column in yellow, that is where you will indicate, does the mentee meet the standard or need work to meet the standard, based on their evidence, based on your discussions, your clinical reasoning tool discussions. It does say not applicable, however, that selection wouldn't be one that you would make for this particular indicator on clinical reasoning. In the midterm mentor report and CRT section, you're going to answer this question. I have used the clinical reasoning tool to discuss at least 2 clinical cases with the mentee. And then in the comments and recommendations from the mentor, we are asking you to, in particular, include your observations of the mentee's demonstrated clinical reasoning skills. Also, in the midterm mentor report and CRT section, We just wanted to point out that the clinical reasoning tool mentorship version is linked right there for you, along with a guidance document on how to use the clinical reasoning. Isn't required again. Of course, you may continue to use it as an educational or coaching tool, but the college doesn't specifically require you to use the tool again. However, if the mentee receives a rating of needs work to meet the standard at the midterm, then there is a bit more that's required. So firstly, the clinical reasoning indicator will populate in the midterm report automatically as a red flag indicator that still needs work. And as a mentor, you will be commenting in the midterm report on how clinical reasoning will be addressed during the remainder of the mentorship period. The mentee must prioritize clinical reasoning as a learning goal for the second half of their mentorship. If the mentee receives a rating of needs work, we are going to ask, or we do require you as a mentor to conduct the CRT with the mentee for 2 more clinical cases by or at the final evaluation. And you will also be commenting on the mentee's progress with clinical reasoning from the midterm to the final evaluation in the final mentor report. So we wanted to address this question that we thought some mentors may have, which is, what should I do, or what should a mentor do if there are continued concerns with a mentee's clinical reasoning? So our guidance to you in this type of situation is, if the concerns are considerable and you feel as a mentor that they don't seem remediable during the course of the mentorship period, then that's when we would like you to contact the college, and you would contact me directly for that in that type of situation. So we have reached the end of our session. Just a note that the recording and the slides for this webinar and the clinical reasoning audio examples will be posted on the mentorship program webpage, so you will be able to go back. I think we are at 1 minute past 1, but Sarah and I can stay to answer any questions. Do we have any questions, Jessica, that have come through?
Yes, I have one that says, actually I have 2. The first one is, would it be possible to know if the CRT is available in French?
The CRT is being translated into French, and I believe the translation is done. So the CRT will be posted in French within, I would say, a week or so.
Well, okay. And then my other question is, can the tool be used, so can the CRT tool be used in teaching with students as well?
Yes, this is Sarah speaking. Absolutely. This is a tool. We do a previous webinar on the use of this tool that is free for you as registrants to use in other ways. It could be a great tool, both for the student, again, as well as yourself in that role as a supervisor, which of course is very different to being a mentor with a mentee. You're more there supporting, facilitating, whereas obviously with a student, you might be taking a much more educational role as well. So absolutely, it's there for your use. Anything else, Amida?
No, I totally agree. I think it's a great tool to use in lots of different situations. Sarah and I were discussing how we've heard people use it, you know, when they first hire people sort of as part of
New
the
employee.
orientation. Yeah, you can do this with colleagues just to discuss cases, use it as a framework. So
Yeah.
I think it's a very useful tool, and you can for sure use it with students. I will just also sort of confirm what Sarah was saying, which is with a student, students are supervised. So you're more in a supervisory role. In the mentorship, these are initial registrants. So they are registered to practice with the college, and they are accountable for their own practice. As a mentor, you're not supervising your mentee, but you're supporting and guiding and facilitating. But you're not taking responsibility for their clinical decisions.
I have 2 more questions. I don't know if you'd be interested in answering them. The first one is, I had written down a note about 5 cases, but also 2 cases. Can you clarify the number of cases we are required to review with this mentor tool with the mentee? So this, I believe, is coming from a mentor.
That's a good question.
Sure. Yes, I will clarify that. So in the mentorship process, we are asking you to do 2 clinical cases at the midterm. And then if the mentee receives a meets the standard rating, you don't necessarily have to do any more with the clinical reasoning tool. If they get a needs work rating, then we want you to do 2 more clinical cases by the final. So we're asking you to do 2. You can do more. If you'd like, you can do as many as you want in terms of the number of cases that you would discuss using the tool. But we're asking you officially to do 2 at the midterm. I hope that makes it, I hope that clarifies it for you.
And then I think I have another question. I don't know if it's from a mentee or mentor, but they said this only applies to initial practice registrants, but not placement students. This is for initial registrants.
This is only for mentees that we're talking about today.
Yeah. All of the requirements we've gone through today, or this whole webinar, is all about the mentorship. So using it as a mentor with a mentee. You can use it with students, as we mentioned before, but the information today is for initial registrants, or i.e. mentees.
And I have one last one, and it's not a question. It's just, I've been getting actually a lot of feedback saying that everyone found this to be really helpful. And one person just wrote, thanks so much. I'm ready to start a new mentorship this month. I appreciate the comprehensive review of the CRT.
Oh,
excellent.
That's great.
Yeah.
Thank you very much.
And you know, I think it would be great to hear feedback, right, Samida? Because you as mentors and mentees are kind of the first round that will be using this starting October 1st, 2020. So I feel like we certainly will be reaching out for some feedback in the future. Any additions or comments, or yeah, that would be most helpful.
Yes, thank you very much for that comment, and thank you all who are still watching for joining us for this mentor training webinar. I'd like to thank Sarah and Jessica for their contributions today for the presentation, and all of you who are mentors. We want to thank you very much for the contribution you're making as mentors. It's very important for the profession, both of our professions, and it's very important for the college as well. So thank you. If you have any questions, please contact me directly, and enjoy the rest of your day. Stay safe and stay well. Thanks.
Thanks so much, Samida.
Thanks, Samida.